Hi, this is Elliot Fishman, and welcome to the August 2020 CTisus quiz. We've collected 10 terrific cases for you. We hope you enjoy them, and let's get started. In this first case, I ask, what is the most likely diagnosis? If you look at the images, you see what looks like at first a cystic lesion, but then you realize that's the entire pancreas, and you look at it on the axials and then coronal views, you realize what you're dealing with is a long tubular cystic lesion, which, again, you might be thinking about different cystic tumors. Then you recognize you're really looking at the patient's main pancreatic duct. The whole duct is markedly dilated. So when you think about it that way and you look at the answers, it's not a pancreatic adenocarcinoma, but it could become one. I don't see a solid mass at this point. It's not a serous cystadenoma or a pseudocyst. Those could be cystic lesions, but this is a main duct IPMN. It's a little bit unusual in terms of appearance. Usually we see more pancreatic tissue around the duct. Often the ducts will be large throughout the gland, but not necessarily. And this is just a really good representation of a bit of an atypical case. If you look a little bit closer at the area of the pancreatic duct here near the head of the pancreas, there was actually an early foci, and this patient had a high-grade dysplasia in a main duct IPMN. Remember, everyone considers main duct IPMNs to be pre-malignant or malignant etiologies, and those patients will get either a Whipple's procedure or a total pancreatectomy, depending on the scenario. In this case, I asked, what's the most likely diagnosis? And there are 4 really good choices. If you look at the case, now what you see is a dilated pancreatic duct and a transition in the junction of body and neck of pancreas. If you look very carefully at these 2 coronal views, you see there's a soft tissue density which abruptly cuts off the patient's pancreatic duct. Remember what we say is if you see a dilated pancreatic duct, it's pancreatic cancer till proven otherwise when there's an abrupt cutoff of that duct. Yes, we could see an enhancing lesion like a neuroendocrine tumor, which causes a desmoplastic reaction obstructing the duct, but then you would see an enhancing lesion. So when I think about what this could be, it's not a main duct IPMN, it's not a serous cystadenoma, and it's not a pseudocyst. It's a classic pancreatic adenocarcinoma with a main duct cutoff. Just a very nice example of that etiology. The most likely diagnosis in this case is, and I've given you 4 choices. When you look at the images, you see what it looks like an enhancing lesion in part with some draping of vessels in the head of the pancreas. There's no dilated pancreatic duct, though I admit it's hard to see the pancreas in detail. There's no intrahepatic ducts. The lesion is enhancing, and it pushes on the duodenum. So when you think about it, the first thing to ask yourself is, where is the lesion starting? So I'm saying it's pancreas, and it's not duodenum, and it's not in the pancreaticoduodenal groove. And then you say, what are the possibilities? Well, one possibility, of course, is that this could be a neuroendocrine tumor. SPEN tumor, not so vascular. Serous cystadenoma. Well, remember we've said that serous cystadenomas can look like neuroendocrine tumors, but the vessels are stretched and the enhancement is not as great. And if you look really hard and often on the venous phase imaging, the cystic paces are better seen. So this was not a neuroendocrine tumor, and this was not an adenocarcinoma. This was a serous cystadenoma. Again, serous cystadenomas, Linda Chu wrote a paper a couple of years ago, can be very vascular. They splay the vessels. It can be somewhat tricky separating from a neuroendocrine, but the most likely diagnosis is B, a serous cystadenoma. The best diagnosis in this case is, well, you see a liver mass. It's vascular in the 6 or 7 centimeter range. The liver is not cirrhotic. And when you look and you go from arterial to venous, the lesion is barely visible. When you look at the arterial phase, in addition to the homogeneous enhancement, it enhances like the IVC in terms of brightness, not the aorta. There's also a central scar. And yes, I know central scars can be seen with hemangiomas or even hepatomas, but the classic lesion, vascular as bright as the IVC, central scar, quickly becomes isodense. is very classic for focal nodular hyperplasia. Hepatomas, hepatic adenomas, and hemangiomas, all in their own right, can become isodense, but hemangiomas have peripheral puddling. Hepatic adenomas don't have that central scar, nor do they have that homogeneous enhancement. And hepatomas tend to be more irregular in terms of enhancement and in terms of shape. The best diagnosis in this case is focal nodular hyperplasia. What's the most likely diagnosis in this case? Well, I see a mass, and the first thing is trying to figure out, is this mass coming from the stomach or from the spleen? On the axials, I would be hard-pressed to be certain. On the coronal views, I think there's calcification in the lesion, and I think it's simply probably going to be pushing on the patient's spleen. So then you think about, what could it be? Well, if it was splenic and primary, you could think of splenic lymphoma. But really, when you look at it, it really is gastric. Now, the thing about it, it's exophytic, and lymphomas can be at times exophytic, but they're more bulky. Adenocarcinoma is typically more infiltrative and not exophytic. This is a classic appearance of a GIST tumor. Now, it's not the most classic GIST tumor I've seen, and it is somewhat difficult, and at times when GIST tumors push against the spleen or go toward the adrenal bed or pancreas, it can be somewhat confusing, but the homogeneous enhancement, the calcification, all push me to the right answer, which is a GIST tumor. Now, in this case, what's the best diagnosis in this 50-ish-year-old female? Well, what do you see? You see a cystic lesion in the body tail of pancreas, but the lesion has septations within it and almost a soft tissue component. Yes, you could think about a serous cystadenoma, and at times SPEN tumors can be cystic, though the age is bad. IPMNs can have septations, but then you would have to worry this is an IPMN with malignancy. Also, it's large for an IPMN. The hint that the patient's in their 50s pushed me to the lesion of an MCN, mucinous cystic neoplasm. These lesions can have septations, they have ovarian stroma within them, and you can see the soft tissue densities within the mass, and this was an MCN. MCNs are at a minimum pre-malignant, so they will be resected. So just a very, very nice example. In this case, the patient's 20-ish, and we see a pancreatic mass. What pancreatic masses occur in 20-year-olds? It's not going to be the typical adenocarcinoma or even IPMNs unless the patient has maybe von Hippel-Lindau. Mucinous cystic neoplasms of patients in their 40s and 50s and more commonly in the body. Serous cystadenomas is something we always consider. I've showed you some examples recently of very atypical serous cystadenomas, though this is not as cystic as a typical serous or even an atypical serous cystadenoma. So that brings me back to the 20-year-old, and the best diagnosis is a SPEN tumor, solid papillary epithelial neoplasm. Usually in the teens, can be cystic or solid or a combination of both. Very sharply marginated here, which is a very classic finding with SPEN tumors. Now, what's the most likely diagnosis in this case? What I'm showing you are bilateral adrenals that are calcified. Okay, very straightforward. The adrenals are calcified and they're small. What can cause this? Well, prior hemorrhage can cause that, but bilateral prior hemorrhage, the patient would be Addisonian. Okay, this patient wasn't. Neuroblastoma, you would see masses. Neuroblastomas commonly have calcifications, but not the small. They're large masses with calcification. And myelolipoma, you'll see the fat and punctate calcifications, and they're not bilateral. This is good for TB or histoplasmosis, so histo is the best diagnosis. Small atrophic adrenal glands. Patients with histo and TB or TB can become Addisonian, so that's an important diagnosis to make. What's the most likely diagnosis in this case? It's interesting, you see a mass in the pelvis on the left side that seems to be enhancing, and indeed it was. I guess in theory, without delayed images or pre-images, you could say maybe this calcification, but I'll tell you, this was all enhancement. And then you say, where is it? Is it in the pelvis? Is it a pelvic mass? Well, you notice it's coming from the small bowel, or it's at least adjacent to the small bowel. One of the things about small bowel tumors, particularly GIST tumors, they grow exophytically, and sometimes you really don't recognize where they come from. Lymphomas are solid masses, can be multiple various appearances in the small bowel, but they do not enhance. Adenocarcinoma, infiltrative, can be bulky, but again does not enhance. And this is not unopacified small bowel. So this was the best diagnosis as a GIST tumor. If I would have said carcinoid in the possibilities, that wouldn't be bad as well. Though I think when I see something coming off the bowel and being exophytic, I think GIST, intraluminal, then I'm more compulsive for saying carcinoid tumor. Now this is an interesting case. This patient had a history of GI bleed. And when you look at it, particularly well seen on the MIP, is those prominent vessels in the patient's cecum. Really prominent vessels. There's also some prominent vessels, though less well visualized in the patient's descending colon at the level of the crest. And you can see the prominent vessels as you look at the patient's MIP imaging. So the best diagnosis, this is not a cecal cancer, though cancers can have increased vascularity. It's not lymphoma, and it's not the appearance of Crohn's. Crohn's, you get a comb sign, and you see thickened bowel. This is angiodysplasia. Very nice example, angiodysplasia with AVMs in the patient's cecum. This is not an uncommon cause of bleeding, can be seen in large bowel or small bowel. So with that, I've shown you 10 terrific cases. I hope you enjoyed the cases. I hope you got them right. But more importantly, I hope you learned something from the cases. So with that, I thank you for your attention, and I'll see you next time. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website CTisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.